Speaking of pre-excitation syndromes and how to understand them, we need to go back to the normal conduction system of the heart. As a rapid review, you know that this is the sinoatrial node. The sinoatrial node where the impulse is generated, and then it propagates through the atrial bundles where they collect together in the atrioventricular node, as you can notice here. This is the atrioventricular node. You know that the AV node, it has a decremental properties. These decremental properties means that it has a slower conduction and it makes a delay in the conduction from the atria to the ventricle. Why does that happen? It is made in order to ensure that the atria contracts before the ventricular depolarization and contraction happens, so that the atria would contract before and then the ventricles would contract later. So the impulse propagates from the AV node into the His, and which divides into two branches, which are the right bundle branch and the left bundle branch. What is the pre-excitation exactly? Pre-excitation means that there is a segment of the ventricle has been pre-excited before the normal transmission of the impulse happens. And how does that happen? It happens because of the presence of an accessory bundle that connects the atria and the ventricle directly, bypassing the normal conduction via the AV and the His bundle. So this is called the bundle of Kent. And as you can see here, this bundle directly transmits the impulse from the atria to the ventricle. This bundle, it has unique properties. Number one you should know is that it can be present on the left side or it can be present on the right side, connecting the right atria to the right ventricle, or directly the left atrium to the left ventricle. And the other thing is that it has a bidirectional conduction flow. So either it can conduct the impulse from the atria to the ventricle in this direction, so either in this direction, or it can conduct the conduction from the ventricle to the atria in the opposite direction. So how does this accessory bundle manifest on the ECG? As we said, that this is the normal conduction of the heart, where the signal is transmitted from the sinoatrial node through the atrial bundles to the AV and then to the His, left bundle, right bundle. This is the direction of the normal impulse. And on a normal QRS, on normal ECG, there will be a P wave, then the QRS complex, then the T wave. The QRS represents the ventricular depolarization. When this bundle, accessory bundle, is present, what will happen? We said that the AV node, it has a decremental properties and causes, it slows down the conduction from the atria to the ventricle. But this bundle, the bundle of Kent, it does not have this decremental properties. It does not have these decremental properties, so there will be an area of the ventricle that will depolarize first, and this depolarization will appear on the ECG like this one, as you can see here. This is the depolarization, the early depolarization of the ventricle that comes from the accessory bundle, and this is called the delta wave. So what are the properties of the accessory pathway on the ECG? It will has a short PR interval, and then the delta wave, as you can see here, that this is the delta wave, and a wide QRS complex in total. So those are the manifestations that you will see on the ECG. And what is the clinical significance actually? What is the clinical significance of this bundle? The clinical significance of this bundle, it acts as part of the atrioventricular re-entry tachycardia, the AVRT, atrioventricular re-entry tachycardia. Atrioventricular re-entry tachycardia, it will not occur without the presence of this accessory bundle. But how can it manifest on the ECG? That depends on the route of transmission of the tachycardia and the route of the loop itself. So let's say this is the bundle. This is the bundle of Kent, the accessory pathway. The AVRT, it has two types, atrioventricular re-entry. It is a re-entry tachycardia. First of all, let's explain what is it is atrioventricular. It's not within the AV nodal itself. It's not within the AV node itself. It's not within the sinoatrial nodal itself. It is the re-entry circuit is composed from both the atria and the ventricle. That's why it's called the atrioventricular re-entry tachycardia. But it has two types or two manifestations. One of them is called the orthodromic and the other one is called the antidromic. So what's the ortho and what's the anti? That depends on the circuit. How does it propagate? Orthodromic means when the circuit propagates through the correct path, through the normal path, as you can see here, from the atria to the AV node to the His bundle, and through the bundles back to the accessory pathway in the opposite direction, in the opposite direction from the ventricle back to the atria, but in the correct path. You can see the circuit in the correct path from the AV node to the His bundle. This is called the orthodromic pathway. Orthodromic pathway, when it passes through the correct path, the circuit circles within the correct path from the AV node to the His bundle to the bundles, ventricles, but back through the accessory pathway. How will this manifest on the ECG? It will manifest by the presence of a narrow complex tachycardia, and it can be treated as any kind of tachycardia. But the other type, which is the antidromic, it means it passes through the opposite direction. The circuit loops in the opposite direction. What does that mean? It means directly from the atrium through the accessory bundle to the ventricles, through the bundles back in the opposite direction to the His, to the AV node, back to the atria. This is called the antidromic AVRT. How does it manifest on ECG? As it passes through the opposite direction, definitely it will need a longer period of depolarization for the ventricles to occur, and it will manifest with a wide complex. As you can see here, it is a wide complex tachycardia. In brief, a short PR interval, a delta wave from the depolarization of that part of the ventricle, and then a wide QRS complex. So what is the presentation and what's the clinical significance? The clinical significance of this, it comes, patients present with palpitations. They present with palpitations. Does this palpitation increase, or the presence of the accessory pathway, does it increase the risk of sudden cardiac death? The answer is no. It does not increase. It does not increase the risk of sudden cardiac death by itself. But unless there is an atrial tachyarrhythmia that like atrial fibrillation. So the clinical importance comes when there is an atrial fibrillation. This will result in atrial tachycardia, and it will be transmitted faster. This atrial tachycardia will be transmitted faster through the accessory pathway, resulting in antidromic AVRT. So if there is an antidromic AVRT, a wide complex tachycardia that is irregular, we should think that this is an atrial fibrillation with an accessory pathway, which is an antidromic, definitely, because it is a wide complex. And here comes that this is a really significant and should be treated correctly, where other medications, regular medications that are used for supraventricular tachycardia, they should not be used for this purpose. Here is a real ECG. This is a patient who has a short PR interval as you can see here, and there is a delta wave. There is a delta wave here. This is short PR and this is a delta wave, and it is apparent in here with short PR interval, delta waves, and a somewhat wide QRS complex. So what's the next step of this for this patient? What should I do if he presents with palpitation and he comes to you and you find this ECG? What should I do? The next step is to go for Holter monitor. I should put for this patient a Holter monitor in order to see if there is any atrial fibrillation. Does this patient develops any atrial fibrillation, runs of atrial fibrillation on the Holter or not, and are they present all the time, or just they are intermittent appearance? Intermittent appearance of this delta wave carries a very good prognosis, while the presence of atrial fibrillation runs carries a worse prognosis for the risk of developing wide complex antidromic tachycardia. How should we treat them?